Okay, hi everyone, my name's Fatima. Today I'm going to be presenting about obstetrics and gynecology OSCE scenarios. In particular, it's going to be about obstetric history. We'll go through what the structure is for an obstetric history, obstetric OSCE scenarios. We'll go through speculum examination and vaginal swabs, obstetric abdominal exam, gynae history, gynae OSCE scenarios, and vaginal examination. I've pasted in a pre-session and post-session feedback form. If you can fill that in, that would be great, please. We'll start off with obstetric history framework. Have a think to yourself, or you can paste it in the chat. What's the structure of an obstetric history? Right, so for an obstetric history, firstly, it's a history in an OSCE scenario or even in practice as well. You start off with introducing yourself and asking for consent. You ask about the presenting complaint, and then you'll ask them further about their history of the presenting complaint. In an obstetric history, we use the FRAB screen, which stands for fetal movements, rupture of membranes, abdominal pain, and bleeding, and we'll talk more about all of these in a moment. We then go on to a systems review, so we ask them about the rest of the systems, any other symptoms that they've experienced. We'll ask them about this current pregnancy, any past obstetric history, any past pregnancies that had been complicated, any gynecological or sexual history that of relevance. We'll do an ICE, so ideas, concerns, and expectations. So we'll ask them, what do you think is causing this? Is there anything in particular that you're worried about? And is there anything that you're looking to get out of this consultation or your visit to the doctors? And then we'll go through the rest of a normal history, which includes past medical history and past surgical history, drug history, which includes any kind of medications, any allergies, and if they have any allergies, what happens if they do take that medication, for example, their family history, and then social history. And social history would include alcohol, smoking, and drugs. And in particular, for the obstetric history, we'll go through what else is important for a social history. So in terms of introduction and consent, you're introducing yourself, you're confirming the patient's identity, confirming their gestation, and then you're explaining the purpose of this whole consultation, and you're gaining consent as well. This is important because it builds rapport, it's essential for OSCE marks, and it puts the patient at ease and it ensures that the patient has understood what's happening. You then go on to presenting complaints. So you ask them what's brought you in today, and you give them this golden minute and you allow the patient to speak uninterrupted. They might complain of things including vaginal bleeding, reduced fetal movements, abdominal pain, headache, vaginal discharge, or contractions. These are the main things that a woman can come in if she's pregnant with complaining of. We then, as we mentioned, we go on to the FRAB screen. So the FRAB screen, as we said, starts off with fetal movements. So you ask the lady, she might say, I'm feeling reduced movements. A positive finding would be reduced movements after 28 weeks. It changes between each mother and baby in terms of how many contractions and how frequent they are, but generally from around 18 to 24 weeks, contractions should have started happening. It's important to know, well, fetal movements are important to monitor. And if a lady comes in saying she's got reduced fetal movements, then it's important because causes of it could be intrauterine growth restriction, it could be multiple pregnancies, it could be a stillbirth, hypoxia to the baby, or even placental insufficiency. After fetal movements, you'll ask about the rupture of membranes. So have you passed water or have you broken your membranes? You'll ask them, had you had a sudden gush of fluid? Was it continuous leakage? When did it happen? Was it painful? Are you in pain at the moment? And if they had had a rupture of membranes, things that we're thinking about would be premature rupture of membranes, so PROM, which happens if it's more than 37 weeks, or preterm, pre-labor rupture of membranes, which is PP-ROM, which is less than 37 weeks. It could be an infection that's causing this. It could be urinary incontinence, so it might not be a rupture of the membranes. And you ask about what it looked like as well. So if it was meconium stained, then you might be thinking fetal distress. If it's blood stained, then could it be a uterine rupture or an abruption? If it was pus stained, could it be an infection? We then ask about abdominal pain. So A in the FRAB is abdominal pain. With abdominal pain, you treat it how you treat pain in general in an OSCE scenario. So you do the Socrates, which is site, onset, character, radiation, associated symptoms, timing, and anything that exacerbates it, and the score out of 10 of how painful it is. And you'd ask them also about some safeguarding. So had you actually was there any trauma to the area? Had you hit the area? Causes to abdominal pain. If it's an early pregnancy, we're thinking, is it a miscarriage or is it an ectopic pregnancy? And with ectopic pregnancy, you might even get pain in the shoulder. In late pregnancy, we're thinking about placental abruption, about preeclampsia, rupture of the uterus, or even it could just be contractions. And then other causes can include appendicitis, a UTI, or cholecystitis, so non-obstetric, non-gynecological kind of causes. Important to note that appendicitis in pregnancy can cause pain in unusual places because it's not necessarily in the umbilical, then the right inferior area. It could, because the anatomy is distorted from the gravid uterus. And then we move on to bleeding. And for bleeding, we're looking at the quantity of blood, how many pads. You can ask them, so to know the quantity, you can ask them how many pads have you gone through, any clots that have come out, and any pain as well. In early pregnancy, if there's bleeding, we're thinking, again, miscarriage, ectopic pregnancy. If it's in late pregnancy, then we're thinking, is it a placental abruption? If it is, then it would also be painful. Is it placenta previa? That would be painless. Is it vasa previa, which is a rare but critical pregnancy complication where fetal blood vessels, they cross the cervix and it's unprotected by the placenta or the umbilical cord. And then other causes could be, is it an ectropion, is it a polyp, or is it malignancy? We then move on to systems review. Now, in systems review, we're asking them about the rest of the system. So any chest pain, any changes in bowel habits, any weakness on one side of the body, or changes in your vision. In particular, for an obstetric history, other systemic questions that can potentially lead you to think of a diagnosis could be, for example, in preeclampsia, they would get swelling or puffing of the hands and the face. So you can ask them about any swelling or puffing in the hands and the face, any visual disturbances, any headaches, or any epigastric or right upper quadrant pain. That leads you to think preeclampsia. In intrahepatic cholestasis of pregnancy, it's if they've got itchy palms and soles, if they've got scratch marks, if it's worse at night, and if there is no rash. And for thromboembolism, you're thinking chest pain, shortness of breath, and calf swelling. These are conditions that are quite common to come up, especially when it's an obstetric history. We then move on to asking about any current pregnancy history. So in terms of gestation, you're asking about the dating scan, anomaly scan, midwife, or is it consultant-led? Because if it's midwife-led, then there's less likely to have been any complications. If it's consultant-led, then potentially the scans have come up with something positive. Ask whether it's being conceived via IVF or not. any complications that have happened so far. For example, have they been diagnosed with gestational diabetes or preeclampsia, intrauterine growth restriction, or placental previa? Has any of this stuff come up in the booking visit tests? And then you're asking also about the blood group and the rhesus status. Important to note, has this woman been given anti-D if she's rhesus negative? And then you move on to the past obstetric history. So asking about gravity and parity. So gravity would be the total number of pregnancies that she's had, and parity is any births that she's had that are more than 24 weeks. The year of when she gave birth to all of these previous pregnancies, gestation at delivery, and mode of delivery, any complications that have happened, so postpartum hemorrhages, any preeclampsia, gestational diabetes mellitus, because that all increases the risk of her developing these conditions again in this pregnancy, and then the birth weight as well, because again, it could be a common trend between her children. And then in terms of red flags, we're thinking if she's had a previous C-section, because then that sometimes it depends on the type of C-section, but it determines how she then delivers in this pregnancy. Any previous preterm births, any previous stillbirths, any recurrent miscarriages, and any previous shoulder dystocia. Again, these are all important because the baby at this pregnancy can be at risk of these complications if she's had these kind of complications before. Then we move on to past gynecological or sexual history. So we're asking about the menstrual history. How long is the menstrual cycle normally? Has she had a history of any STIs? Any previous issues with contraceptives as well? For example, has she had an ectopic pregnancy before? Has she had cholestatic symptoms with the combined oral contraceptive pill before? Because if estrogen in her system through a pill has caused cholestatic symptoms, then in pregnancy, when hormones are increased, she could be more prone or at risk of cholestatic symptoms. And so intrahepatic cholestasis of pregnancy could be a risk to her, which in itself comes with its own complications to the mother and to the baby. So it's important to monitor and know this stuff. And then any blood pressure issues as well, because then she'll be at risk of preeclampsia. Now, further to that, endometriosis and fibroids. If she's had a history of endometriosis or fibroids, then these can come in they are anatomically in the area of the pregnancy, so she can present with any complications with that, and then previous smear results as well. Now, in terms of red flags for gynecological sexual history, it would be if she's had any previous ectopics, because there is a risk of reoccurrence, pelvic inflammatory disease, because then that can cause a risk of infertility or ectopic risk as well, and then previous cervical surgery, because that causes a risk of preterm labor, for example, LETS procedures or cone biopsies. And then ideas, concerns, and expectations, as we mentioned before. And then in terms of past medical history, you're asking about any hypertension, any diabetes, any epilepsy, any thyroid disease, autoimmune disease, and thrombophilia. Hypertension important because that means she's at risk of preeclampsia, for example, and she needs to be managed with particular medications during her pregnancy if she's hypertensive. In terms of diabetes, again, metformin, either lifestyle, either metformin or even insulin, is how we manage patients with gestational diabetes. And if she's got diabetes, then she's likely to have it during her pregnancy as well. In terms of epilepsy, what kind of medications is she on? Because if she's pregnant, she can't be on particular kinds of epileptic medications like sodium valproate. And you have to keep monitoring because pregnancy can predispose to seizures in epilepsy. Thyroid disease as well, because you need to change the dosing of her levothyroxine, for example, autoimmune diseases, and thrombophilia as well, as we mentioned. Because if she's had thrombophilia in the past, then she's going to have to be on medications to prevent any risk of clots. In terms of her past surgical history, as I mentioned, previous C-sections and the type of C-section, uterine surgeries, myomectomies, and LETS procedures, because these are all predisposed to risks of preterm labor or risks of complications. And in terms of the red flags of the medical history. Any cardiac disease is very important to note because being pregnant will exacerbate the cardiac disease, previous uterine rupture, and bariatric surgery as well. Bariatric surgery, important to note because ladies who've had bariatric surgery, absorption of vitamins like B12 and iron and folate would be reduced than in a normal lady without bariatric surgery, and so they need to be monitored more regularly, and for example folic acid, they need to take the higher dose. Then in terms of drug history and allergies, you're looking for any regular medications that they're on because you'd probably want to continue them and double check that they're not teratogenic. Are they taking folic acid at the moment? Because if not, they should be taking folic acid and aspirin. Double check if they are on aspirin, because if they are on aspirin, why are they on aspirin and when was it started? Was it during pregnancy or prior to that? Because if it was during pregnancy, then it was started for a reason. And then, of course, double checking the medications if there are any teratogens, for example, any ACE inhibitors, retinoids, methotrexate, sodium valproate, antiemetic. These all should be stopped and an alternative medication should be given instead. Herbal supplements as well. In terms of social history and then allergies, as we mentioned, you asked what allergies and what happens if you do get an allergy. And then in terms of social history, smoking is very important to ask about because ladies that smoke more at risk of having intrauterine growth restriction to the fetus, placental abruption, and even miscarriage. Alcohol, because that can also predispose to issues. Drug use and home support. Important in obstetric history, you're asking about home because ladies that are pregnant are more likely to be predisposed to all sorts of issues and safeguarding concerns. Any domestic violence, you need to ask this sensitively. And if they're under 18, then you do the under 18 safeguarding as well. In terms of family history, preeclampsia in the family, because it's known that there's a 4-time increase if the mother of that lady had preeclampsia, hypertension, thrombosis, any diabetes in the family, multiple pregnancies, any genetic disorders as well. And the red flags you're looking for are any clotting disorders in the past, because then they could be predisposed to DVTs and PEs, which are very serious, and any strong preeclamptic history as well. Now, we move on to case 1, which is a 28-year-old lady that at 8 weeks, she presents with vaginal bleeding. What are the kind of questions you would ask this lady? Put it in the chat or have a think about it. What kind of questions would you ask if this kind of scenario came up in your OSCEs or in clinical practice? So kind of questions that we would ask is, firstly, she's coming with vaginal bleeding. What are the other symptoms that she's presenting with? So we're doing the FRAB screen, okay? So any reduction, well, she's 8 weeks pregnant, so she wouldn't really have any fetal movements. So we won't be asking about that, but we'll be asking about any, and again, rupture of the membranes. It's less likely to happen at 8 weeks, so we won't be asking about that. So what we've got is the bleeding and pain, okay? So we're asking, is she in any pain? What was the amount of bleeding? How much was it? How many pads did she go through? It's important to know about the pain characteristics as well. So we're doing a Socrates for the pain, because if it was unilateral pain, that would make you think of something like ectopic pregnancy in comparison to shoulder tip pain, which again makes you think of ectopic pregnancy. In terms of the bleeding, the amount, if it's heavy bleeding, if there's any clots, you're thinking of a miscarriage. If it's minimal bleeding, then is it a threatened miscarriage? You're asking about other questions like dizziness, any previous ectopics, because you're thinking, is she more likely to have this ectopic? IVF as well can predispose you to miscarriages, for example, and then rhesus status as well, because you're thinking, does she need anti-D injections or not? And then dizziness, because have they lost sufficient amount of bleeding for it to cause anemic kind of symptoms? Do they require blood transfusion, for example, as well? Red flags to this would be if it's a severe unilateral pain, you're thinking ectopic, which is serious and needs to be treated. Especially if an ectopic is very painful, then you're thinking of doing a surgical management to it. Syncope, if they are syncopus, then is it ruptured? Is it a ruptured ectopic? Again, you're thinking to do surgery. If so, and is there syncope because they are so anemic? Do they require blood transfusion? And then shoulder tip pain as well. We're thinking ectopic, intra-abdominal bleeding is what causes the shoulder tip pain because it puts pressure onto the phrenic nerve, and that is a sign of ectopic pregnancy as well. Other symptoms of hemodynamic instability other than dizziness can be fainting or palpitations as well. Again, these all suggest ruptured ectopic pregnancy. Differentials, as we said, miscarriage, ectopic pregnancy, molar pregnancy as well, okay? And differentials, in particular for a miscarriage, it would be because of bleeding and pain. For ectopic, it's the shoulder or the unilateral pain and hemodynamic instability. And for molar pregnancy, it would be excessive nausea. It would be if you did a blood test and you saw a very high beta HCG, if the uterus is enlarged, larger than it states. And in terms of the plan going forward, things that you could say would be, or things that you would do would be to assess the hemodynamic stability. You would do bloods, you will do observations, you do a beta HCG to double check miscarriage, not miscarriage. You will then do a transvaginal ultrasound as well. You'll see where the pregnancy is it actually a miscarriage or is it an ectopic? And it, as mentioned before, anti-D if her rhesus status is negative. Next case, 32 weeks pregnant lady with severe headache. What are the questions that you would ask? Have a think about that. What are the differentials as well? And then what would you plan to do further? So in terms of the questions we'd ask, start off asking about visual changes, any visual disturbances. And by the way, when we say what questions to ask, remember you're doing the full obstetric history, but in terms of the systemic and the FRAB screen, these are the particular things to highlight and to pick up on, okay? So any visual changes, meaning any photophobia or any confusion, because these can all indicate some sort of neurological involvement. You'd then ask about any epigastric or right upper quadrant pain, because this can happen because of liver involvement in severe preeclampsia or even HELP syndrome, which is hemolytic, elevated liver, low platelet syndrome. That happens, that is a severe kind of preeclampsia. And you also ask about any facial or any hand swelling, because that can help identify if there's any fluid retention that is associated with hypertension and preeclampsia. It's also important to ask about fetal movements, because reduced movements might suggest placental insufficiency. And what is their blood pressure history? Had they been hypertensive prior to pregnancy? Any family history of hypertension? Any family history of preeclampsia as well? Main differentials, we're thinking preeclampsia, HELP syndrome, as we've just mentioned. Other possible differentials can include things like meningitis, especially if they've got neck stiffness and photophobia. Could it be just a migraine or a tension headache? Or even venous sinus thrombosis. So don't forget even rarer causes that you would suggest for a non-pregnant lady when you're doing a history. It's similar in pregnancy, and if anything, ladies are probably even more predisposed to it. But obviously preeclampsia, it needs to always be ruled out first because of the maternal and fetal risk. And the reason why we've got venous sinus thrombosis in the mix is because ladies can be at a higher risk of clotting due to pregnancy. Then in terms of the plan, what would you do further? It would be neurological exam, including reflexes, and that is important in all differentials, but a brisk reflex is a sign of preeclampsia and any impending eclampsia as well, eclampsia being the seizures. I'd also assess maternal observations, so you do blood pressure, you do urine protein as well, because that can, if there's any protein in the urine, then again you're thinking of preeclampsia. You arrange further tests, further maternal blood tests like LFTs and platelets, because you're looking to assess HELP syndrome, and then any further to that would be fetal monitoring as well to make sure that the baby is okay. Next case, reduced fetal movements at 39 weeks. What are the further questions that you would ask? What are your differentials and what would your plan be? So the questions we'd ask is, when were her last fetal movements, and whether this is a change from the baby's normal pattern or not. Because persistent reduction can indicate placental insufficiency. You'd ask about any other associated symptoms like any abdominal pain or vaginal bleeding. These might suggest placental abruption. It's important to ask about pregnancy complications like any gestational diabetes that she's been diagnosed with, hypertension, or any known fetal growth restrictions, because these all increase the risk of fetal distress. In terms of your differentials, the main differentials could be just a normal fetal sleep cycle, yeah? Or it could be placental insufficiency, could be an abruption, could be previa, causing the fetal hypoxia. Placental insufficiency causes fetal hypoxia, by the way. Abruption, previa, as mentioned, or it could just be maternal factors like dehydration or any medications that she's taking like opioids, benzos, sodium valproate. So that's why it's really important to ask about drug history. And in terms of the plan, to assess the fetal well-being, we just do a CTG, which stands for cardiotogography. Okay, we do that immediately, and then further investigations are done if any abnormalities are detected. So you do an ultrasound scan if CTG is abnormal. Next case, woman 1 hour after delivery is now bleeding heavily. What are the questions you'd ask, differentials, and your plan? Just because I'm conscious of time, we'll ask about, I'll move on and say that we'll ask about the amount of bleeding and whether the placenta has been delivered. And if it has, was it delivered intact or not? Because retained placental tissue can cause ongoing bleeding, if you remember the 4 T's as well. I'll also ask about whether the labor was prolonged or was it induced, because that increases the risk of uterine atony. So was she given oxytocin or not? And it's important to ask about trauma during delivery or previous postpartum hemorrhages, because these are additional risk factors as well. It's also helpful to know if this is a multiparous patient, so if they've had more than 3 deliveries, because more than 3 deliveries increases your risk of atony, as does primiparity. Also, it's helpful to know the details of the delivery. So was it vaginal, or was it C-section? Was it instrumental, episiotomy? Were there any tears, any sutures required? Differentials that we're thinking about, key ones, you follow the 4 T's. So tone, which is uterine atony, that's the most common. Trauma, so that's why we're asking about, did any trauma happen to the area? What is the mode of delivery? Because, for example, instrumental deliveries are more likely to cause trauma. If it's a C-section, then she's unlikely to have any trauma from down below. Tissue, any retained tissue, and thrombin, okay? With uterine atony, it's the most common. And then plan would be rapidly assess the patient's clinical status. You do an A2E, and then you identify the cause of bleeding through examination and investigations. You're obviously 100% going to be calling for help. you put in the IV access, you're giving uterotonics, and if it's A to E, then again, there's other stuff like fundal massage, bimanual pressure, considering taking to theatres as well for any of the other T's, okay? Case 5, 24 weeks gestation, and she's got abdominal pain. Again, just because I'm conscious of time, I'll say that what to ask is, firstly, you want to distinguish between any benign causes from any serious obstetric complications. So I'd ask first about the nature of the pain, its location, its severity, and whether it's constant or intermittent, because constant severe pain raises concerns for placental abruption, whereas intermittent might suggest preterm contractions. I'd also ask about associated vaginal bleeding, because painful bleeding strongly suggests placental abruption, while painless bleeding indicates placental previa. It's also important to ask about fetal movements, because reduced movements might indicate fetal compromise. And I'd ask about urinary symptoms like any dysuria, pain when you're urinating, frequency, or fever, because urinary tract infections are common in pregnancy and they can present with abdominal discomfort, and they might even trigger preterm labor. Differentials to include would be clarify whether the pain worsens with movement or position, because that might suggest round ligament pain. Benign cause related to, which is a benign cause related to stretching of the ligaments as the uterus grows. But main differentials here would include placental abruption, preterm labor, urinary tract infection. With abruption and preterm labor, these are the most concerning because they threaten the maternal and the fetal well-being. And then plan would be assess the maternal observations and the fetal well-being, and arrange appropriate investigations to determine the cause of pain. Now, vaginal speculum and swab examination. How's it done? What is done? When to perform it? So you normally perform it if there's any abnormal vaginal bleeding in a pregnant lady, or if there's abnormal vaginal discharge, for example. If they're pregnant, you ensure firstly that there's no placental previa diagnosed. That needs to be excluded first, because if you were to perform it with placental previa, it can cause complications. Other than vaginal bleeding, abnormal vaginal discharge, if there's any postcoital bleeding, if there's during cervical screening as well, and if you're investigating any STIs, then this is when you're doing vaginal speculum and even swabs. In terms of the examination steps, you start off by introducing yourself and you confirm the patient's identity. You explain the examination, and it's very important that you explain exactly in detail how it's going to happen, because if you say, I'm going to put a speculum or whatever this is down below, that's not accurate enough, and during the examination they might be in shock, because you hadn't explained that it's going to go into the vagina. And then you also need to obtain consent. You offer a chaperone, because it's an invasive, intimate kind of procedure. You gather your equipment and ensure that there's good lighting, which is very important, because if there's not good lighting, you won't really be able to see anything. And so equipment includes your swabs, and in the next slide you'll see further equipment to that. You need to position the patient in a lithotomy position, which is what the image is showing. You then inspect the external genitalia, so you're inspecting the vulva, you're looking for any ulcers, because that would make you think of genital herpes, any abnormal discharge. Differentials for that would be candidiasis, bacterial vaginosis, chlamydia, any scarring, which can be because of lichen sclerosis, vulval vaginal atrophy, which happens in postmenopausal women. Commonly, any masses like a Bartholin cyst or any malignancy, and if the lady has had FGM, which is total or partial removal of the clitoris and or the labia and or narrowing of the vaginal introitus. You then palpate the inguinal lymph nodes, and that's to identify any lymphadenopathy, which might be associated with any acute infection like chlamydia and herpes, or if it's one-sided rather than both-sided, then vaginal cancer. And then you're doing vulval swabs. Vulval swabs, it's literally the vulval area, which is the outside. You're swabbing for any vulval ulcers to exclude syphilis or herpes, for example. And then you do a vulval vaginal swab, which is from the vulva into the vagina, basically the introitus kind of area. And again, this is to look for any chlamydia or gonorrhea. To do it, you pass the tip of the swab through the introitus approximately 5 centimeters into the vagina, and you rotate the swab for 10 to 30 seconds against the vaginal walls, and then you remove the swab from the vagina, and then you swab the vulva around the introitus as well, and then you open the test tube from the packet, and an assistant can help with opening the test tube as well. And it's important not to spill any of the fluid from the test tube or place the swab on any surface, because then that can contaminate the sample. You insert the swab into the test tube and you snap the swab against the side of the test tube along the indicated black line, and then you screw the lid on the test tube as well. To watch videos of how to do this, you can just go on Geeky Medics as well. As mentioned, this is the equipment. So you'll be using a speculum right here. You've got the swabs, you've got the test tube, it's called the NAAT. You've got the further viral swabs, you've got gloves, you've got lubricant, that's very important, gauze and tissues, etc. as well. And that's what a speculum looks like when it's open. That's what it looks like when it's closed. And you're looking at this particular plastic thing that you're twisting around, because when you're moving it, when it's open, you're then closing it, okay? And then this is what it looks like when you're inserting the speculum, and I'll explain it in a second. You're inserting it sideways, and then you twist it when it's in. So lubricate the speculum and insert it at 45 degrees. Okay, so sideways, and then you rotate it up and open the blades. Okay, and once you open the blades, you can then visualize the cervix, and then you're doing high vaginal swab. Okay, but before that, when you're visualizing the cervix, okay, inserting the speculum, you separate. Before you actually even insert the speculum, you're separating the labia, okay, with your fingers, using your thumb and your index finger of your non-dominant hand with the blades closed, and then you're gently inserting the speculum using speculum insertion with the handle pointing sideways at 3 o'clock. And then once inserted, you rotate the speculum so that the handle is now facing upwards at 12 o'clock, and you open the speculum blades until an optimal view of the cervix is achieved, and then you tighten the locking nut to fix the position of the blades. To visualize the cervix, you're looking in particular at the cervical os, because that will give you an idea about any miscarriages, whether it's open or whether it's not. You're looking for any erosions around the os that's associated with any ectropion. However, any cervical cancers can look similar as well. Any cervical masses, that's typically associated with cervical malignancy. Any scarring from a previous colposcopy procedure, like Let's procedure. Any foreign bodies, like a tampon or a condom, or a coil, and any atrophy that can happen likely in postmenopausal patients. Then in terms of the high vaginal swab, this is to detect any infections like bacterial vaginosis, Trichomonas vaginalis, Candida, Group B strep. With the speculum in situ, you pass the tip of the swab through the speculum to the posterior fornix of the vagina, which you can see here. This is the cervix, okay? This is the vagina, this is the posterior fornix. You rotate the swab in the posterior fornix, and you ensure you swab any discharge present as well, and you remove the swab and insert it into the tube from which the swab was removed. Okay, and then endocervical swab is used to perform microscopy, culture, and sensitivity for any gonorrhea. So you pass the tip of the swab through the speculum to the cervical os. You insert the swab gently into the cervical os. If there is excess discharge covering the cervical os, consider using a spare swab to remove this before you insert the endocervical swab. Rotate the swab in the endocervix, and then you remove it and insert it into its test tube. And then to remove the speculum, you need to do it slowly. So with your non-dominant hand, you hold the blades of the speculum whilst you loosen the locking nut, which is here. Yeah, this is the locking nut. With your non-dominant hand, this then ensures the blades do not snap shut when the locking nut is loosened. You gently remove the speculum while slowly closing the blades, and you inspect the walls of the vagina. Okay, cover the patient with the sheet and explain the procedure is now complete, and provide the patient with any privacy so that they can get dressed. You then give them any paper towels for them to clean themselves, and you dispose of the used equipment into a clinical waste bin, but not the swabs. The swabs are going to the lab. Now, positive findings on a speculum include if it's normal, then it will look pink, smooth surface, there'll be a closed os on the cervix. If it's abnormal, like for example in cervicitis, it will be a red or inflamed cervix and discharge. In cervical ectropion, it will be a red glandular area, and in cervical polyp, there'll be a protruding lesion, and in cervical cancer, irregular bleeding mass. So here you can see cervical ectropion, and here you can see a neoplasia, okay? Now, obstetrics abdominal exam. When do you perform it? You're doing it during routine antenatal visits as well, but it's to assess the fetal well-being, estimate gestational age, identify fetal lie and presentation, detect the multiple pregnancies as well. In terms of the examination, you introduce yourself, confirm the patient identity, explain the examination, and obtain consent. So you'll say, I'm going to be feeling your tummy, feeling for the position of your baby and listening to their heartbeat and measuring as well your tummy, okay? And you're getting consent. You're then gathering your equipment, which includes measuring tape and a stethoscope, and more likely now they use Doppler. And then you put the patient in the correct position on the bed. Their head should be 30 to 45 degrees up. In late pregnancies, you ask them to go onto their left lateral position, okay? And this is to avoid compression of the abdominal aorta and the inferior vena cava by the gravid uterus. You're inspecting from the end of the bed. You're looking for any pain, obvious scars like C-section scars, any pallor, which suggests anemia, any jaundice, which suggests obstetric cholestasis, any edema of the arms, legs, and the face, which suggests preeclampsia. You're looking at the hands more closely. You're doing inspection of the hands. So you're looking at their color, okay? If there's any poor peripheral perfusion, then you're thinking of any hypovolemic shock. Or if there's cyanosis, that might suggest hypoxemia. You're looking then at any edema that might be, firstly, it might be normal finding in late pregnancy, but if it's widespread, then it can suggest preeclampsia. Palmar erythema is normal in pregnancy as well. And if there's any itching rash, then it might suggest obstetric cholestasis. You're feeling the temperature. Cool hands might suggest poor peripheral perfusion. You've assessing the capillary refill time. If it's greater than 2 seconds, it suggests poor peripheral perfusion, which could be because of an antepartum hemorrhage. Okay, and then the need to assess capillary refill time is important for that. And then radial pulses as well. You're feeling for the rate and the rhythm. Okay, you're then looking up at the face for any jaundice, again, obstetric cholestasis, any melasma, which is benign, dark, and irregular hyperpigmented macules, which is normal in pregnancy, any edema, again, preeclampsia, we're thinking about that, and any conjunctival pallor, which suggests anemia. You're looking at the abdomen, you're doing an abdominal inspection of the shape of it and of the surgical scars. You're looking for any fetal movements. They're typically visible from 24 weeks gestation. Scars include, if it is a C-section, what kind of? Is it a midline cervical, a vertical, or is it the Fanon style? Other things to look out for would be linea nigra, which is a dark line running vertically down, and it's a normal finding. There's striae gravidarum, which is reddish or purple lesions that develop due to overstretching of the abdomen, commonly referred to as stretch marks. And then you've got striae albicans as well, which are stretch marks which appear silver-like in color, as you can see around here, and they're less pronounced as well. And then for the actual examination, so you're going to start off with abdominal palpation. You're just going to palpate, light palpation over the 9 regions to identify any tenderness or masses, for example, in appendicitis. Then you're feeling for the uterus, and you palpate the uterus to identify its borders, including the upper and the lateral edges. At 12 weeks gestation, the uterus will be at the pubic symphysis, as you can see here. At 20 weeks, it will be in the umbilical area, and at 36 weeks, it will be in the xiphoid process of the sternum. And then you're assessing fetal lie, and fetal lie refers to the relationship between the long axis of the fetus with respect to the long axis of the mother. So you place your hands on either side of the patient's uterus, ensuring that it's facing the patient. Gently palpate each side of the uterus. One side of the uterus should feel full in nature, and that would be because the fetus's back is there. So here it would be on the right side, and then on the other side, you may be able to feel the fetus's limbs, okay? And that's important to determine the fetal lie. So here it would be a normal fetal lie. Here it's transverse, so it's not normal if it's late in pregnancy, depending on how many weeks in pregnancy they are. Fetal presentation, further to that, is the next thing that you're doing. So this refers to which anatomical part of the fetus is closest to the pelvic inlet. So you assess the gravid uterus to determine the fetal presentation. You place your hands on either side of the lower pole of the uterus, just above the pubic symphysis. You apply firm pressure to the uterus, okay, angled medially, palpating for the presenting part. A hard, round presenting part is suggestive of cephalic presentation, okay, which is that the head is in the pelvis. A broader, softer, less defined presenting part, for example, the fetus's bottom or legs, is suggestive of a breech presentation, which is abnormal, depending, though, on how many weeks they are far into the pregnancy. You're then assessing fetal engagement, and that is a fetus is considered engaged when more than 50% of the presenting part, so their head, is descended into the pelvis. The fetal head is divided into fifths when you're assessing engagement. If you're able to feel the entire head in the abdomen, they are 5/5 palpable, meaning they're not engaged. If you're not able to feel the head at all, it's 0/5 palpable, meaning fully engaged. You're then doing symphyseal fundal height measurement, and that is symphyseal fundal height is the distance between the fundus and the upper border of the pubic symphysis, okay? So you're using a measuring tape and you're placing it at the pubic symphysis and at the upper border of the fundus. After 20 weeks, the symphyseal fundal height should correlate with the gestational age of the fetus in weeks, plus or minus 2 centimeters. You begin by palpating the abdomen, just inferior to the xiphisternum, using the ulnar border of your hand. You locate the fundus of the uterus, which is, you'll feel a firm feeling edge at the upper border of the bump. Once the fundus has been identified, you locate the upper border of the pubic symphysis. You measure the distance between the upper uterine border and the pubic symphysis in centimeters using the tape. And the distance measured should correlate with the gestational age in weeks, as mentioned, plus or minus 2 centimeters. To avoid bias, it's best to place the tape face down and only turn it to view the numbers once in position. And then finally, you're assessing their fetal heart. So using here an ultrasound probe, a Doppler ultrasound probe, or back in the day, you used to use a Pinard stethoscope. But you're basically placing it where you think is the area between the two shoulders of the baby. And you're applying gentle pressure to ensure that there's a good seal, okay? And then you're listening for the heartbeat. Positive findings: breech presentation, transverse lie. So as you can see, transverse is here. Breech is when the head is up and the legs are down towards the pelvis. Small fundal height, when you're doing the symphyseal fundal height measurement, it can suggest a small gestational age or intrauterine growth restriction. Large fundal height can suggest large gestational age or macrosomia, which is an absolute birth weight of more than 4,000 grams or 4.5 kilograms, regardless of age, whilst large gestational age means it's a relative measurement, so it's more than the 90th percentile for that gestational age. And then polyhydramnios and multiple pregnancies as well. Polyhydramnios is a condition characterized by excessive amniotic fluid surrounding the baby. Now, in terms of gynecological history, so the way we go by gynecological history is similar to general histories and similar to obstetric history. Introduce, ask for consent, presenting complaint, history of presenting complaint, if it includes pain or anything else. You can use the Socrates approach as well. And then the specific one for gynae is MIS course. And then you do a systems review. MIS course stands for menstruation, sexual history, contraceptives, obstetric history, any urinary issues, rectal issues, and any previous smears that they've had in the past. Ideal concerns, expectations, past medical surgical history, drug history, allergies, family history, social history as well. In terms of MIS course, so menstrual history, you're asking about when their last menstrual period was. Is it normally regular, irregular? What's the length of bleeding? The length between the periods as well. Menopausal age. If they've reached menopause, what age did they reach menopause, and what age did they first get their first periods? So that's the menarche age. If they are pregnant, if there's a possibility that they could be pregnant, if there's any bleeding, if the bleeding happens, is it during periods? And if so, is there any menorrhagia? Okay, because if there's menorrhagia, so heavy bleeding, your differentials are fibroids, dysfunctional uterine bleeding, which is hormonal, it could be adenomyosis, number of pads that they've gone through, have they ever bled through before? Is the bleeding intermenstrual? Is it between periods? Is it during postcoital, so related to intercourse? Or is it postmenopausal? And in postmenopausal, differentials would be atropic vaginitis, cervical or endometrial polyps, or endometrial cancer even. Endometrial cancer risk factors would be hyperestrogenic state. So that's why it's important to ask what age did they get their period and what age did they get menopause, because if it's early menarche, late menopause, then there's more estrogen in the system, so they're more likely of endometrial pathology. Nulliparity, if they haven't had kids before, if they are obese, if they've got diabetes, if they've used HRT, and if so, for how long and what type of HRT, because that all increases estrogen in the system. And then systems review, you're asking for any fatigue, any loss of consciousness in case they're anemic because of the blood loss, pain differentials. You're asking for pain as well, and your differentials would be endometriosis, chronic pelvic inflammatory disease, could be GI or bladder causes as well. Is the pain cyclical or not? Because if it's cyclical, is it related to menstruation? If it's not, then it could be something non-gynecological, for example. Then in terms of the sexual history, you're asking them, do they have regular partners? Any previous STIs? And if so, how were they managed? Were they cleared of the infection? Did they do a test after they were treated? Any dyspareunia? And if so, which is pain during intercourse, is it deep or is it superficial? Any discharge? Any postcoital bleeding? In terms of contraceptives, which is the next one, what type of contraceptives? What previous ones have they used? Have they had any side effects to them? What is their adherence like? Are they actually taking their pills, or are they missing them between days? Obstetric history, gravity and parity. So how many pregnancies have they had in the past? How many of them were actual births? Any terminations, any stillbirths, any live births, any miscarriages as well? What was the mode of delivery? Was it C-section? Was it natural vaginal? What was the weight and age when they were born? Any complications after? Did they need to get any surgeries in the area or anything like that? And then for the U, it would be urinary symptoms. So how often do they urinate? Do they need to urinate in the night? Is the urine painful? Is it smelly? Do they get incontinence? And is that incontinence triggered by coughing, sneezing, urgency to go to the toilet? Is it exertional? Is it BMI? Is their BMI high? Are they a smoker? Are they chronic cough or asthma? Because differentials of urinary incontinence would be stress urinary incontinence, and that would be, for example, when you're sneezing and coughing. Or is it urge urinary incontinence? That's urgency to go to the toilet. Is it mixed? Both? Is it pressure from fibroids or pelvic masses? How does this affect their quality of life? Because some ladies can be very, very, very affected by incontinence, and it can definitely affect their quality of life. And so depending on how it affects their quality of life, that might lead you to think about what kind of treatments or how far to go with the treatments for this lady. And then any previous treatments as well. Their caffeine and fluid intake as well is very important. And then for R, it would be rectal. So are they feeling any dragging sensation? If so, is there a rectal prolapse? Are they experiencing any diarrhea, constipation, or any incontinence? And then for the S, it would be smear. So when was their last smear? What were the results? Any further investigations or treatments further to that? Have they had colposcopy in the past? Any LETS procedures or any managements for any abnormal smear results? You do the ICE, so ideas, concerns, expectations, any past medical history. So that includes fibroids, endometriosis, gynae cancers, breast cancer, and then drug history. So that includes allergies as well. So oral contraceptive pill, have they had that in the past? And we did ask that in the contraceptive part. Any herbal remedies, any allergies, what kind of reaction they have to it. In terms of family history, any inherited conditions like the BRCA genes, these are significantly increases the lifetime risk of ovarian cancer as well. Lynch syndrome, which is an autosomal dominant condition caused by mutations in mismatch repair genes, and that leads to lifetime risk of endometrial cancer, 40 to 60%, and a 10 to 12% risk of ovarian cancer. And then social history, that includes smoking, alcohol, drugs, and work as well. Case 6 is a 25-year-old woman comes in with pelvic pain. What are the questions you would ask? What are your differentials? What's your plan? Questions to ask is when her last menstrual period was, because pregnancy must always be excluded, okay? The location of the pain is important to know as well, and the severity of the pain, and you do a Socrates approach to that. Severe unilateral pain raises concerns for ectopic pregnancy or ovarian torsions, which are both surgical emergencies. You ask if there's been any fever or any vaginal discharge that suggests pelvic inflammatory disease, while sudden pain after exercise might indicate a ruptured ovarian cyst, for example. STI history as well, important to know in case of PID differential and dyspareunia as well. Differentials, as we mentioned here, ectopic pregnancy, ovarian torsions, pelvic inflammatory disease, ruptured ovarian cyst, endometriosis, adenomyosis as well, and non-gynae causes can also cause pelvic pain. And then the plan would be to confirm any pregnancy status, to do a pelvic examination, and then to do any imaging to determine the cause of the pain, for example, an ultrasound. Case 7 is a heavy menstrual bleeding. What are the questions to ask? What are your differentials? What's the plan? Questions to ask: clarify the amount of blood and the presence of any clots or any flooding, because this helps determine the severity and the risk of anemia. How often are they changing their pads or their tampons, for example, okay? Is there any clots, any flooding? And then what about symptoms of anemia? So do they have any loss of consciousness? Are they fatigued? Any palpitations? Things like that. Intermenstrual bleeding raises concerns of endometrial pathology, while pelvic pressure symptoms might suggest fibroids. Adenomyosis typically causes painful, heavy periods in multiparous women. As we said, fibroids, adenomyosis, endometrial pathology, hormonal dysfunction as well, and miscarriages. These can all cause bleeding. That is quite heavy during periods. So plan would be to investigate for anemia, so do blood tests for blood count, arrange imaging to identify any structural causes as well, do a pregnancy test to exclude a pregnancy, pelvic ultrasound, as we mentioned, and gynecological referral if it is heavy and they require further management to treat, for example, their fibroids, such as surgeries. And then for postmenopausal bleeding, what are the kind of questions to ask? What's differentials and what's the plan? For postmenopausal bleeding, it should always be treated as endometrial cancer until proven otherwise. I would ask when their menopause happened, because bleeding more than 12 months after menopause is abnormal. Risk factors like obesity, HRT, tamoxifen, these increase the risk of endometrial pathology. Other causes include an age of menarche as well, if it's earlier age of menarche. If they've had any children, as we mentioned before, if they're nulliparous, then increased estrogen in the system, so more at risk. History of diabetes, and then any weight loss or systemic symptoms like any fevers, lethargy, appetite reduction, night sweats. These are all changes in weight. These are called floor symptoms that make you think of a cancer. So as we mentioned, endometrial cancer is a very important differential diagnosis. Endometrial hyperplasia would be the other one. And then other causes include polyps or atrophic vaginitis as well, but malignancy must be excluded first. So then my plan would be to arrange urgent investigation of the endometrium with imaging and further assessment. Important to note as well, in terms of newer guidance on postmenopausal bleeding in those on HRT, if they've been on HRT and they've got this bleeding within the 6 months of starting it, or within a change in the dose of HRT within 6 months of changing the dose, then it doesn't need investigation. But if it's longer than this, then you need to refer for an ultrasound, and then onward a 2-week wait referral if it shows a thickened endometrium. In those not on HRT, then it's a direct 2-week wait referral, no ultrasound is done first. They'll do an ultrasound within the 2-week wait pathway. Case 9, 14-year-old attends the clinic requesting contraception without her parents present. What questions do you ask? What is the plan? Questions to ask, very important. This is quite a serious scenario. Not to say that the rest aren't, they're all serious, but this is quite important because it's a safeguarding kind of issue. So to ask about their sexual activity, are they currently sexually active? How old is their partner? Is the relationship actually consensual? Are they at risk of any coercion or any pressure? Do they feel safe at home and in the relationship? Have they tried any STI? Have they had any STIs? Any STI symptoms? Any STIs diagnosed in the past? Any past medical history or medications that they take as well? And what contraceptions are they interested in? You then do a Fraser-Gillick competence kind of assessment. So you need to assess the ability to understand, the ability that they understand contraception and consequences. So Gillick competence is the principle that practitioners use to judge capacity in children to consent to medical treatment. Fraser guidelines are used specifically for children requesting contraceptives or sexual health advice and treatment. Your differentials here that you're thinking about, firstly, are they a competent minor that is requesting contraceptives? Is this a safeguarding concern? Any sexual exploitation happening? Is there an STI risk here? So plan to go forward would be further to firstly assess the Fraser competence, to assess if there's any safeguarding issues, to offer any STI screenings, and then if they are competent, then you can provide contraceptives if appropriate. And it's important to note that you need to maintain confidentiality unless there is a safeguarding risk. So even if they've attended without their parents present, it's not your place to go and tell their parents. You need to maintain this confidentiality if they are Fraser competent. The next case is a 19-year-old requests contraceptives. What are the questions to ask? So the case that involves a 19-year-old requesting contraception, this is a common OSCE counselling station. I would begin by exploring her sexual history, including whether she is currently sexually active, whether she has one or multiple pregnant partners. I would also ask about her last menstrual period and her risk of pregnancy, because it's important to ensure that she's not already pregnant before you're starting contraceptives. I'd also ask about previous contraceptive use and preferences, as well as medical history that could influence contraceptive choices, such as if she smokes, if she's got migraine with aura, if she's got a history of blood clots, because these all prevent you from prescribing contraceptives like the hormonal contraceptives. It's also important to assess any STI risk and symptoms and offer screening if appropriate. The key considerations are whether she's suitable for combined hormonal contraceptives that requires a progesterone-only method, or would she benefit from long-acting reversible contraceptives as well. So Options include the combined oral contraceptive pill, progesterone-only pill, the intrauterine system, there's the copper coil as well, progesterone injection that lasts 12 to 13 weeks, contraceptive implant, condoms, or even sterilization. So it's important to also know, does she want to get pregnant in the future, and when so, because then you would be using reversible rather than irreversible, such as sterilization forms. And then plan would be, firstly, you need to exclude the pregnancy, so do a pregnancy test. You need to assess their UK MEC eligibility for contraceptives. So that would be asking the questions of smoking, migraine, blood clots, those kind of questions. Discuss the contraceptive options with them. All right, so give them the different options, give them the side effects that can happen, how long they last for, and then offer STI screening as well, especially if you're going to put in a system or a coil, because if you do not do an STI screen prior to that and they do have an STI, and then you insert the coil will then drive that infection up into the uterus, and then they can be at risk of pelvic inflammatory disease, which is very serious and requires antibiotics and sometimes requires admission into hospital as well. So very important to offer STI screening. And then case 11 is patients come in with smear results showing high-grade changes. Questions to ask. Red flag symptoms such as postcoital bleeding, intermenstrual bleeding, any pelvic pain, or any abnormal discharge. These might suggest invasive disease. I'd also ask about previous smear results and HPV vaccine status. The main differentials here that we're thinking about would be CIN 2, 3, early cervical cancer or cervical inflammation, so cervicitis, although high-grade dyskaryosis most commonly reflects high-grade CIN. And then the plan here would be to urgently refer to colposcopy within 2-week wait, where the cervix can be examined and biopsies are taken. And then treatment can be offered like LETS procedure as well, and high-grade CIN if that is confirmed, but you need to make sure you've consented them in terms of the fertility, because LETS procedures can increase risk of infertility or preterm births. Next case is a 32-year-old woman trying to conceive for 18 months, and she's got difficulty with it. She comes in and she's saying, I've been trying for 18 months and I still haven't been successful. What are the questions that you're going to be asking here? How often do you have intercourse? Okay, because it should be around three times a week. Are periods regular if they're trying to conceive? Are periods regular? Is there any history of any STIs or pelvic inflammatory disease in the past? Because pelvic inflammatory disease can cause complications such as infertility. Previous pregnancies or any previous miscarriages, any symptoms of PCOS, okay, polycystic ovarian syndrome, any acne, any hirsutism. This can predispose to infertility as well. And then, what is the partner's fertility history? Has the partner ever had children with a different partner, proving that they are not infertile or they haven't had infertility in the past? Differentials here would be PCOS, as we mentioned, could be tubal factors, okay? So that could be, is there endometriosis causing pressure on the tube, blocking the tube and blocking the ovary from, blocking the egg from getting from the ovary to the actual uterus, therefore causing infertility? Is there a male factor infertility? Is there endometriosis, as mentioned? Is it unexplained infertility? Plans would be, you do the fertility investigations for both the partners, and those would be blood tests, those would be ultrasound scan for the lady, blood tests for the male partner, assessing their sperm as well. Case 13, 28-year-old with pelvic pain for 6 months. What questions would you be asking here? Pelvic pain for 6 months has a broad differential. I'd ask whether the pain varies within the menstrual cycle, because cyclical pain suggests endometriosis or adenomyosis. I'd also ask about dyspareunia and heavy or painful periods, which also point towards endometriosis. Bowel symptoms like bloating or altered bowel habits might suggest IBS, irritable bowel syndrome, while urinary frequency or bladder pain could suggest interstitial cystitis. A history of STIs or pelvic inflammatory disease is important because chronic infections can lead to ongoing pelvic pain as well. So key differentials include endometriosis, chronic pelvic inflammatory disease, endometriosis, irritable bowel syndrome, bladder pain syndrome. And the plan then would involve pelvic examination, imaging like ultrasound, and you can consider laparoscopy if you're thinking endometriosis is suspected, or MRI. Case 14, 55-year-old woman with involuntary urine leakage. What are the questions you'd ask? Differentials, what would the plan be? This scenario involves urinary incontinence, which is common in gynecological OSCEs as well. I would further clarify the pattern of the leakage, ask whether it occurs during coughing, sneezing, suggesting it's stress incontinence, or whether it follows a sudden urge to urinate, which suggests urgent incontinence because of an overactive bladder, for example. I'd also ask about urinary frequency, nocturia, fluid or any caffeine intake, as well as any obstetric history, since vaginal deliveries can weaken the pelvic floor support. And then you ask about, after their deliveries, did they do any pelvic floor exercises or not? Because pelvic floor exercises are usually recommended for ladies to do following their deliveries to prevent incontinence in the future and strengthen the muscles. The main differentials include stress incontinence, as we mentioned, urge incontinence, overactive bladder, mixed incontinence, could be a mix of both, is it overflow incontinence, and even urinary tract infections. And then plan would be to ask the patient to complete a bladder diary. You do urinalysis as well to rule out an infection, perform a pelvic examination to assess the pelvic floor function, and you can use a SIM speculum. Specifically, when you're doing uro-gynae examinations, you're not going to be using the speculum that we mentioned previously when you're doing speculum vaginal exam. For this one, you're using a SIMS speculum. And when you do a SIMS speculum, you need to make sure that they're lying on their side, okay? And that's what a SIMS speculum looks like. And that assesses for any vaginal wall prolapse. Right, so vaginal examination, this is the final thing before we end. Vaginal examination, when do you perform it? You perform it to assess the cervix, to evaluate the uterus size, to detect any adnexal masses, adnexal being near the tube ovaries as well, and to identify any tenderness. So you start off by introducing yourself, confirming the patient's identity, explain the examination, and obtain consent. Again, you're being specific, saying that in this examination, I will insert fingers into the vagina, okay? Offer a chaperone as well, because this is an intimate examination. Gather equipment, and equipment includes lubricant, which is very important because you're going to be putting lubricant on the fingers. And previously with the speculum, you would put lubricant on the speculum as well. You know, use gloves as well, and you're going to have paper towels so that when you come out, you wipe your fingers and see whether there's any blood or something like that, okay? Adequate lighting again is important, and then you start off by doing an abdominal exam, and that would be to inspect and palpate the 9 regions softly. You're inspecting, you're then positioning the patient in a lithotomy position similar to the cervical speculum exam. Then you're inspecting the external genitalia, you're inspecting the vulva, and again, you're looking out for the same things that you looked out on when you were doing the speculum. And then you palpate the inguinal lymph nodes, again for the same reasons as we mentioned previously. And that would be, when you're inspecting, you're looking for ulcers, abnormal discharge, scarring, vulvovaginal atrophy, and FGM. Then, in terms of your vaginal examination, you're examining the vagina by inserting 2 fingers and asking if they're okay when you're doing this, okay? So make sure that they're comfortable during the procedure. Although it isn't the most comfortable, if you keep asking them if they're all right, it puts them at ease. So you separate, so you lubricate the gloved index and the middle finger of your dominant hand. You carefully separate the labia using the thumb and the index finger of your non-dominant hand. And with your palm facing laterally, you gently insert the gloved index and the middle finger of your dominant hand into the vagina. And then you're assessing the vaginal walls. So you're palpating the walls of the vagina for any irregularities or masses. And then you're going further into the vaginal fornices, and the fornices are the superior portions of the vagina extending into the recesses created by the vaginal portion of the cervix, and gently palpating the fornices for any masses as well. And then, so this is what it looks like when and then you go into the cervix. So in terms of the cervix, you're assessing the position, the consistency, so position in terms of his anterior or posterior, consistency, for example, if it's irregular or smooth, and then cervical motion tenderness as well, which is placing your non-dominant hand on the abdomen in the suprapubic region, and you use your 2 fingers inside the vagina, gently move the cervix in all 4 directions while observing the patient for any pain. Pain on palpation of the cervix will suggest pelvic inflammatory disease, okay? And then you're feeling the uterus as well, and you're doing that using a bimanual method. So you place your non-dominant hand on the abdomen in the suprapubic region, and you push upwards with the internal fingers while palpating the lower abdomen with your non-dominant hand. You should be able to feel the uterus between your hands. The uterus might be anteverted or retroverted. Anteverted means the uterus is orientated anteriorly towards the bladder. That's the most common position of the uterus. Retroverted is when the uterus is orientated posteriorly towards the spine, and that's a less common uterine position. For the uterus, you're assessing the size. It should be approximately the size of an orange. The shape, it might be distorted by any masses like large fibroids. Surface characteristics, so note if the uterus feels smooth or nodular, and then any tenderness, again, for pelvic inflammatory disease. The ovaries and the uterine tubes are also assessed. These are called the adnexa, and it refers to the area that includes the ovaries and the fallopian tubes. You bimanually palpate the adnexa, and that would be to position your internal fingers in the left lateral fornix of the vagina. You position your external hand onto the left iliac fossa, and then you perform deep palpation of the left iliac fossa whilst moving your internal fingers upwards and laterally towards the left. And you feel for any palpable masses. You note their size, their shape. Could it be an ovarian cyst, ovarian tumor, a fibroid? And then if there's any tenderness as well. And you repeat the adnexal assessment on the right as well. And then you withdraw your fingers and you inspect the glove for any blood or abnormal discharge. Okay. Now, I know that was a lot to get through. Sorry about that. But what we've done today is, in this session, we went through obstetric history, the structure of an obstetric history, what are the obstetric scenarios that can come up in an OSCE or even in clinical practice, speculum examination, how to perform a speculum exam, how to perform vaginal swabs. We then went through how to perform an obstetric abdominal examination, gynecological history, gynecological scenarios, and a vaginal examination. This session is being recorded and you can rewatch it back. You can speed me up, slow me down, pause me, whatever you helps with your learning. I hope that this session was useful, and there is some feedback, pre-session and post-session feedback forms in the chat function. It would be very, very useful if you guys can fill it in. I'd be very grateful. Thank you for joining us, and I'm going to give it another minute or two for any questions. Thank you for that in the chat. Thank you very, very much. I'll give it another minute for any questions. If you'd like a copy of the slides as well, do mention your email in the feedback form, and I wouldn't mind sending them to you. But again, this is all being recorded, and hopefully you can go back on it. Right, thank you everyone. Have a lovely